So one of the challenges with, in general practice, with managing patients who've had colorectal cancer and had surgery and radiotherapy and chemotherapy is that these long-term problems we're talking about, neuropathy, cystitis, tiredness and fatigue, and we'll be talking about overweight and obesity, are actually really common in our practice. We're used to managing them in various ways, but obviously the context is quite different, and so I think it's something to kind of reflect on and think about, that this managing neuropathy David's just been talking about in the context of someone who's had chemotherapy is different, and we need to have some different expectations and goals in how we might manage that than neuropathy from other causes. So I'm going to present just, this will be quite a short case about Robert, who's a 66-year-old man. At the age of 50, he was diagnosed with hypertension and hypercholesterolemia. And he was put on irbesartan and atorvastatin at that time, and he was reasonably well controlled on that. Okay, so he's had obesity for most of his life, his weight gradually increasing over the years from, he was about 28 BMI in his 20s and increased to 34 by the age of 50. And he tried various diets without any kind of sustained success. He has a sedentary lifestyle. His diet's high in fat and starch. He has high red meat intake, high dairy, low fibre, insufficient serves of fruit and vegetables. He's not a smoker. He's drinking about 20 or 30 grams of alcohol though a day. So just reflecting on that, what do you think could have been done earlier if we at this stage, at the age of 50, when he's had his onset of his hypertension and hyperlipidemia, what could have been done then at this age to try and prevent him from developing colorectal cancer?
Improve lifestyle?
Sorry?
Improve lifestyle? Yeah,
so we could have tried more strongly to encourage him to lose weight. His BMI is 34, so according to the guidelines, he's still not at a BMI where we would really consider surgery, bariatric surgery. So the emphasis still is on lifestyle, but he's failed previously. So it's not going to be easy to address his lifestyle. It's certainly not something that we're going to be able to achieve by just asking him to lose weight and eat more fruit and vegetables and do more exercise. It's going to take more than that. So it's going to require something more intense than that to get him to lose weight. The other thing, of course, is that we should be thinking about colorectal cancer at this stage and thinking about detection of colorectal cancer.
Reduce the meat intake.
Yeah, and the meat, particularly red meat and processed meat, which is associated with increased incidence, and increases fibre.
Reduce alcohol.
So in 2016 he was diagnosed with cancer of the sigmoid colon, and he had open resection, which was complicated because his obesity. He had a high-risk tumour invading the peritoneum and some lymph nodes and lymphovascular and perineal invasion. And so he had a high risk of recurrence at 50 to 60%. He was given 5-FU and oxaliplatin biweekly for 6 months. So again, with all the attendant risks that involves. So he lost some weight during this treatment, but then he regained all of that weight, and his BMI is now 35. He's got some residual sensory neuropathy with minor functional limitations, He's on 3 monthly surveillance checks and has a colonoscopy every 12 months, and he's got no sign of recurrence as yet. So let's think about some questions. So how much do you think obesity contributed to his risk of colon cancer in the first place?
Significant.
Sorry?
It's a significant risk factor.
Yeah, it is a significant risk. How much do you think? We could have put a number on that.
30%?
40%, 50%.
Yeah, it's about a 30% risk, somewhere between 20 to 30% risk, increased risk of developing colon cancer. So at 50, when he was diagnosed with hypertension and hypercholesterolemia, we talked about lifestyle change. What else should we have done at that stage? We've talked about lifestyle change, we've talked about introducing colon cancer screening. What else could we have done?
Get him to modify his diet.
Mm-hmm. Other thoughts? What else would you do? Yeah, consider his alcohol intake. 20 to 30 grams is not a lot, but by Australian standards, but it is. It does increase your risk. Anything else?
I think the other thing you could do is potentially screen him for impaired glucose tolerance, think about giving him an oral hypoglycemic to help with weight management as well.
So he's obviously at risk of not just colon cancer, but he's at risk of diabetes and cardiovascular disease. So sure.
Do a FOBT.
Mm-hmm. Yeah. So we should be encouraging him, more than encouraging him, really stressing the importance of this. So one of the things is, I think it was Winston talked about teachable moment, or David. This is a really critical teachable moment at this age, when he was presenting with these conditions, to really talk about his risks, to explore his family history, and use that as an avenue for really trying to motivate him to do something about his weight, and not relying on brief advice, but actually referring him for more intensive counselling, coaching about his diet, and support for physical activity change. And it would be quite appropriate to do a care plan, as David's mentioned, to try and achieve some of that.
He's an intelligent man, he's an accountant.
Mm-hmm.
Probably if you were to do a full cardiovascular assessment and possibly even sleep study with a BMI of 35, we might be able to convince him to do something about weight and exercise.
Yeah.
That might help him. Because I think that will be essential, and he's got so many risk factors for heart disease as well.
So what about now? Now he's put the weight back on.
Even more so.
What's the importance of doing something about his weight now? Often the attitude is, I've come through this terrible thing, I haven't had a recurrence, gone through all this treatment, I've now got a bit of neuropathy. So it might be a little bit more difficult to do exercise.
He really needs to lose weight even more so.
Why?
So he doesn't get a recurrence or another case.
But
Yeah,
it's
so
recurrence.
it increases his risk of recurrence, yeah.
Would drug therapy for weight loss be appropriate at this stage?
Would what?
Would drug therapy for weight loss be appropriate at this stage?
Well, we don't have any really good drugs is the problem. It would be. We've got naloxone, and that combination that's recently been released, and the other drugs that we've had previously are not very useful long term. He'd be a candidate for surgery, but again, in the context of having already had abdominal surgery, it's not going to be straightforward surgery. It's going to be more complicated to do bariatric surgery at this stage. So it certainly increases his risk of recurrence. So again, from a motivational point of view, we should be really, again, using this as a teachable moment, but it's also difficult. It's going to be hard for him to achieve that. And we've seen that partly by the fact that he regained the weight after he lost it during treatment. So what else, any other thoughts about how you'd manage his weight in practice?
Refer him to one of these group programs.
One of the what?
One of these group programs that are going at the moment.
Mm-hmm. Possibly.
Sydney University weight loss program.
Mm-hmm. Yeah.
Another one at St Vincent's weight
Yeah.
loss program with endocrinology, various other weight loss programs.
Mm-hmm. Is getting to group programs is one of the challenges, and as I'm sure you know, that's a challenge. But group programs can provide more support often. Individual coaching, even telephone-based coaching might be helpful.
The fact that he has put on so much weight, he might even need some psychological assessment. Maybe he's just likely to be very depressed, and he's just totally lost in CBT, and that might help him as well.
Yeah,
You know,
yeah. We don't use psychological interventions for weight management as much as we should, and there is good evidence that they can be effective, particularly combined with obviously dietary and physical activity advice and programs. Using a formal cognitive behavioural intervention with him might be very useful, and it might address some other issues as well. So not a general counselling program, but something that's much more targeted. Okay. So that's just a reminder of again, another issue which in general practice we see very commonly and we're used to managing in the general population, where the context is a little different, but for this patient we really and we see this with other cancers as well. Patients are often have had a weight problem prior to developing cancer, and then developed cancer, and then the weight problem is either returned or continued, and managing it's difficult, but it really requires as much attention as some of the other things that we deal with. Okay, so I'm going to stop there because of time. I'm going to hand over to Melvin, who's now going to talk about shared care.